Hi, everybody. My name is Estherlinda Asante, and my DNP scholarly project was using the DASH diet to manage hypertension in African Americans. So, my committee members, my chairperson was Dr. Tanya Crystal. My mentor throughout this project was Dr. Alberto Fori, and my community member was Miss Stephanie Vaughn. So I'm going to start this presentation with a quiz. The first question is, according to the CDC, what are the two leading causes of death in the United States? The second question is, which race has the highest prevalence of hypertension? And the third question is, in the United States, only about dash out of dash adults have their hypertension under control. So I'm going to give you all a few minutes or maybe a few seconds to think about this question. And on the next page, we're going to have the answers. And you probably might have guessed right. The two leading causes of death in the United States are heart disease and stroke. And you might have guessed this right too. African Americans have the highest prevalence of hypertension in the United States. And only about 1 in 4 adults, which is 24%, with hypertension have their hypertension under control. And this information was from the CDC. So I have this figure or this picture to show the prevalence of hypertension in the United States and how it affects race, the racial differences and the disparity among these ethnicities. So this, even though this was from 2017, we've been seeing a lot of increase in hypertension in African Americans. Comparing the new standard to the old standard, we could see that 46% of the adult population in the United States have hypertension. And among this information or statistics, we can actually tell that African Americans have the highest rate, whether using the old standard or the new standard, in both men and women. So this was really a huge concern that was brought up during my clinical or my preceptor hours that I discussed with the project or the clinic, the site owner who agreed to this project. So the aim for this project was to help control the increase in prevalence of hypertension in African Americans and also to educate African Americans on the benefits of using the DASH diet. My review of literature, I had a dozen literature to use for this project, but the 5 main ones that I will use for this presentation, the first one was by Bangwara and his colleagues. And this article showed, or this study showed, that lifestyle changes decrease blood pressure readings in African Americans in general. The second article was by Baker and his colleagues, and this showed a community-based organization which provided DASH meals to the community members, which were mostly African Americans. And through providing the people in the community with the meals from the DASH list, it showed that the rate of obesity and blood pressure improved, and this was a very long study. It was like for 7 years. Then the third article was by Tyson and his colleagues, and this article showed that DASH diet had a positive impact on African American patients with chronic kidney disease due to the favorable response to the healthy meals over a long period of time. I think this study was also for like 4 years. This led to blood pressure readings going down through the action of the RAS system. We all know that as the renin angiotensin aldosterone system. The fourth article was by Trapper et al., one of my favorites, and this study showed a positive correlation between the farmers market and the community's consumption of fresh produce. So what happened was the physicians PCPs provided the patients, which were African Americans, with coupons to use at the farmers market. And this helped them increase their consumption of fresh produce, and they could see an improvement in the blood pressure readings over some time whilst these patients were consuming the fresh produce from the farmers market. And my last article was by Mehana and his colleagues, and I just threw this in there showing that a combination of two hypertensive medications were more effective in African Americans than other ethnicities. So my theory that I used for this project was Orem's self-care theory. So Orem initially described nursing as the act of caring for an individual need that arises when one is unable to care for self, recover from a disease, and is unable to sustain quality of life as a result of a disease process. Orem believed that caring for an individual did not only entail one person, but a whole community to reach the desired health outcome. She described nursing as a self-effort as well as a community effort. Orem saw nursing as the basics needed for patients to be able to care for self, with an assumption about deliberate action, emphasizing the need to encourage self-care through communication and human interaction. The constant need for improving hypertension in the African American population serves as an example of a self-care deficit that either needs to be addressed through self-care or with the help of nursing systems. So for this project, African Americans will be equipped with the knowledge by nurses to help achieve a favorable outcome. There will be adequate means of communication and human interaction through face-to-face contact to equip the African Americans with the knowledge of using a DASH diet to control their hypertension. So based on this theory, this intervention would help achieve a higher level of self-care and independence needed for an improved quality of life. So my methods used is that this project was a quantitative, prospective, non-experimental quality improvement project, which utilized a pre-test and post-test design. So the data collection spreadsheet was created specifically for this project through an extensive literature review. A recruitment script for each participant was created to ensure that there was no bias in the wording and it didn't have any influence on the participant's decision to either participate or decline. A DASH diet handout was printed from the NIH website, and I used the standard automatic Allen Welch blood pressure machine for both taking the pre and post intervention readings. And one important factor to note in this project was to comply with HIPAA. The spreadsheet excluded all patients' personal identifiers. This was to ensure confidentiality, and all data were coded and transcribed on the data collection tool. So this is a step-by-step intervention of my project, what I went through. The first step was, after the IRB approval, I reviewed the emergency health records at the project site to find potential participants who met the inclusion criteria. The potential participants were contacted face-to-face just before their scheduled appointment time. And this recruitment process, took place from 22nd October to 29th October. It took a week, Monday to Friday. Step 2 was the potential participants were educated on the purpose of the DMP project and were provided with the opportunity to ask questions. The potential participants then could either choose to participate or decline. The next step, those that expressed or wanted to participate and expressed understanding of the project signed an informed consent from Maryville University. I included handwritten alphabet on each signed informed consent to match their blood pressure readings to the post blood pressure reading. And the next step, in step 4, I then collected the pre-intervention blood pressure readings from each participant and wrote the blood pressure reading on the data collection spreadsheet, which was, transcribed using the alphabet. Step 5, the participants were educated on the DASH diet and its benefits. So I gave them printed copies of the handouts on the DASH diet and, kind of serve as a guide for them to use at home whilst making healthy meal choices. Then step 6, the participants were scheduled to return after 6 weeks for a post-intervention reading. Then step 7, the post-intervention blood pressure data was collected on the 6th week and inserted into the data collection spreadsheet. In step 8, the recruitment process ended on 29th October, as earlier discussed, and I scheduled them 6 weeks after the date that the pre-intervention was collected. And the data collection ended on December 10th, which was in 2021. So this is my inclusion and exclusion criteria that I used to select my participant. My inclusion criteria was the participant must be 40 to 70 years of age, have a primary diagnosis of hypertension in the past 6 months, be an African American, obviously, and be a patient at the designated clinic serving as the project site located in the South Central region of the United States in the past 6 months. Some of the exclusion criteria were participants may not be 39 years or younger or 71 years or older. They should not have hypertensive crisis. They should not be a smoker. They should not have certain conditions that might affect their blood pressure readings, which were like cancer, PAD, or AFib, because those are those are conditions that require like specialized treatment that would not fit for this project and will not be controlled using just the DASH diet. So they were excluded. They shouldn't have a BMI of more than 45. They shouldn't be taking medications to increase blood pressure like midodrine, and they shouldn't have uncontrolled pain. They shouldn't have chronic orthostatic hypotension that could affect the results. And also they shouldn't have alcohol or drug dependence or both. So the sample, in total, I had 22 participants, 9 were male and 13 were female. For my data analysis, I used the SPSS statistical analysis to analyze the results. I used the Kolmogorov-Smirnov test to determine the normal distribution of the pre and the post data. So using that, I had a significance value of 0.037. That showed that the data did not follow a normal distribution. So if it had followed a normal distribution, I would have used a paired t-test, but because it did not show a normal distribution, I used the Wilcoxon sign rank test. So based on the statistical analysis, a p-value of 0.001 was reported, which indicated a significant difference between the pre and the post systolic blood pressure readings. So looking at the Wilcoxon sign rank test table here, you can see that 18 participants had improved blood pressure, and 2 patients had either a worse blood pressure reading or the same blood pressure reading from before. So the standard deviation from the pre-systolic blood pressure was increased as compared to the post-systolic blood pressure. And we could see the test statistic table down here on our right. So for the results, I used the paired bar graph, which showed the difference between the pre-test and the post-test. The pre-test is in blue, post-test is in red. And from the graph, you can see that the post-test is mostly skewed to the left, showing an improved blood pressure from the pre-test systolic blood pressure readings. So some of the limitations for this study was a small sample size. I initially estimated a very big or large sample size, but unfortunately I had a small sample size. The limited time in implementing the project, which was 6 weeks, there was no formal method to also measure the participants' compliance to the DASH diet at home. All we know is they said, oh, we followed the diet, but we don't know if they actually did, adhere to the DASH diet at home. So some unintended consequence was the effects of the COVID-19. Due to this pandemic, a lot of patients didn't, show up due to the fear of, getting the COVID from the clinic. And due to the pandemic as well, a lot of patients chose the virtual health. And, one of the requirements for this project was face-to-face contact, so we couldn't do virtual health. And also the increased cost of supplies as a result of non-eligible participants who wanted to participate in the study. To be honest, this project was a very exciting time. The project owner really loved it. So anytime she had patients who had hypertension, who were not even African American, she would just call me, hey, these patients need education on DASH diet. Can you please, help him or her? And I couldn't say no. So due to that, the cost of supplies for printing, for all that kind of increased for me. So that was one of the unintended consequences. And also lack of motivation on the part of some of the participants. Some just didn't want to do it. They didn't see why they should adhere to a specific diet to improve their blood pressure. The missing data, in total, we had 22 patients enrolled, but only 20 returned, which wasn't bad. We had 2 people not return, but it still, gave us a good number to analyze or to use for the data analysis. Some of the strengths for this project was it was easy to comprehend, easy to understand for these patients. Both the DASH diet and the education, they really understood it. And also the convenience of the project sites, because it was right there at the physician office. They come in when they had the appointment. They didn't have to, go to a special place or go choose a special time. It was very convenient for the participants. And some of the barriers was access to food produce required by the DASH diet. So in America here, we know convenient foods are easy to get. Unhealthy, they are also not healthy. So it's hard for some of these patients to get fresh produce. And some actually told me it's expensive because they had to go to the fresh produce section to get these items, which were more expensive than these convenience food. McDonald's is what, $1? You can get whole McDonald's. So that was one of the barriers. And then financial constraints and also cultural and ethnical restrictions. Some people, African Americans, but they didn't, see the type of meal they wanted in the handout I gave them. So that would be one of the recommendations for future research, to kind of, try to find a more diverse list of food to present to the participants that could increase sample size, and also to find a way to record the dietary intake during the intervention period when they go home. And also to increase the time for intervention. We had a very short time for this project. In total, it was like 8 weeks, because there was 1 week of recruiting and 1 week of data collection and 6 weeks of intervention. So that was a very short period of time compared to the studies that I read before that took place over like a very long period of time. And also, if possible, provide these participants with blood pressure machines as a way of incentive to increase participation, and also to help them monitor their blood pressure readings at home. So the implications for practice, for nursing practice, this project showed a very positive outcome, which was the expected result. So that it can be used by clinicians and other healthcare professionals in managing hypertension in African Americans. And it could be used as part of the care plan for these patients. This also was like evidence-based delivery of care, so it can be used and replicated. And also, it decreased hypertension prevalence. It could decrease hypertension prevalence in African Americans. and also increase efficient self-care management in African Americans, as discussed in Orem's theory. For future research and community, future research can rely on the results of this project and also similar projects that has been created like this that could help the African American community, because as I said, the increasing prevalence of this condition keeps going up, and such studies could actually help clinicians help this population decrease this issue or health disparities. So in conclusion to my project, African Americans have seen an increase in hypertension over the years compared to any other race. Several studies have shown that the DASH diet has been helpful in managing this condition. This DNP quality improvement evidence-based project was designed to verbally educate as well as provide handouts to African Americans about the benefits of using the DASH diet in managing their blood pressure. This showed a positive outcome when they adhered to the DASH diet regimen for a period of 6 weeks. This result is beneficial to practice because it shows that this intervention can be used by healthcare providers to control the increasing prevalence of hypertension in African Americans. Taking other similar projects into consideration, this intervention can be replicated anywhere for similar positive results. To control hypertension in African Americans, it is important that the healthcare providers adopt evidence-based interventions similar to this scholarly project for positive outcomes that could improve overall health of African American patients. So, as I said, this project was very successful. The project site, the clinic owner, was very helpful, very excited for this project. It was stressful for me from the beginning, but implementing this project was one of the fun parts of this project, to see how it positively impacted these patients' lives. Some were very excited to do it. They were very appreciative of the information that was given. And to be honest, some didn't even know that this could, be something they could do at home or they could use to help control their conditions. And it just not only, helped improve their hypertension, but also improve their diabetes, those that were diabetic as well. So as I said, in general, this project was very successful. I had a very successful outcome, and hopefully for future projects, some of these recommendations can be kept in mind to create a much more successful outcome. So at this point, I will ask if anybody has any questions. I'll be more than happy to respond. And these are my references. Thank you.